It's a privilege and a pleasure to be here addressing your opening conference. I've already had a little look around the exhibition and the posters, and I'd really like to congratulate everybody for the excellent work that I can see in the posters. I'm hugely grateful to the organizers for asking me to be here. And I will share with you that it's particularly pleasant because actually my first ever research grant was from Hospice UK, which just shows the pioneering approach that hospices and Hospice UK and its predecessor organizations always had. Now, it's not an easy task to look into the future, but for various reasons I'll explain why it's important. And I'm going to look at what does the future hold, and I'm going to look within that at population-based projections, palliative care-based projections, where this then might mean that people are cared for or die. What is the impact of these changes? And, because we will have at, I think, 12:30 today, the Chancellor will be making his budget speech, I've had a little reflection on what I would like from the budget, and you might wish to do the same. So, what does the future hold? Well, let's stand back for a minute from palliative care per se, and just think about societies and healthcare. So, in researching this lecture, I had a look around. So the astronomers have done some projecting. They think we might well go back to the moon. They're not sure if we'll go back to Mars. They're not sure about the space station. Technology and computing is going to be a major continued change, and the speed at which that changes is enormous. And in particular, we will have huge amounts of wearable technologies potentially, which will help us monitor our health in the future, from wristbands, shirts, which will actually generate electricity in this future look, glasses, which will help us navigate, so we won't be having to look at our iPhones anymore because the glasses will be doing it for us, etc. What about healthcare? Well, these technologies will spill into healthcare. And more we have, and we can see them already, virtual consultations, perhaps robotic surgery, minimally invasive procedures, both for investigation and for surgery, with simulations, computerized diagnoses, questions about how that works when the technology fails, perhaps, which is wrong, the computer or the process. And the way in which we use health data is potentially and fortunately going to help us deliver care. The globalization of the electronic health record, I think, is likely to be with us in the future. And that presents major opportunities for early warning and decision support systems. So, for example, in my this system called CogStack has been developed and is already being used in some hospitals, including in London, where you can, it's being piloted at the moment, you can actually merge structured and unstructured data. So all the open free text field can be Googleized in a way with structured data to actually try and identify people who are particularly at risk. And wouldn't that be super if we could identify people at risk of needing palliative care who come into our hospitals more easily than walking around the hospital and looking at them? So we can do alerting. We can actually follow patients over time to observe how things are changing for them. Of course, the challenge of all this, and within all this, is the debate around the privacy that this entails and the ethical and moral dilemmas that this brings with it, as with all the technological advances in healthcare. And we are likely to see increased specialization and complexity, increased challenges to healthcare safely. Workforce for hands-on care, where will that come from, particularly as we see a falling birth rate? And will some professions, this cartoon from The Economist suggested it would be doctors, be potentially squeezed out as we see a greater role for computers and also the caring component of care? The implications for safety are important as health technology becomes more complex. And I would like us to think in palliative care that actually we have an important role in patient safety, something we've neglected in the past, I think. We have focused on quality, but often poor issues around safety relate to poor coordination, poor communication, lack of attention to the detail and individual nature that patients have, as well as the attitude of staff. And this is something potentially that palliative care and hospices can bring with the wonderful things that we see in today's exhibitions as well about the holistic focus of care. And then, of course, we face the issue of resourcing of health and social care. This is an American cartoon. In the future, everyone will have 15 minutes of healthcare coverage, which is a concerning question for us all as we face the issues and challenges on healthcare systems around the world, and the challenges that we can see in many of the newspapers now about the challenges that are facing the NHS. So, taking us on from that, let us think about the new era and landscapes that our population will be facing. And in this, I want to reflect on some of the issues that are raised by aging, by more diseases as people live longer. Living longer is a good news story, but it will bring with it more comorbidity and more issues of survivorship. Now, aging is not specific only to the UK, it's happening across the world, and actually it's happening faster in the more middle and low economy regions of the world. We see increased treatment and longer cancer survival, partly related to increased prevention, earlier detection, as well as treatment. And of course, we have greater awareness, greater physical activity. People try to keep healthier. And so we will see, as the Globocan data shows, an increase in both the incidence and the mortality across the globe from cancers. Let's focus now on the UK data, and specifically, to start, England and Wales. So we face, by 2040 to now, a 25% increase in the annual number of deaths in England and Wales. Now, this is a good news story, and it's caused by two factors. Firstly, the fact that people are living longer, and so deaths reduced and fell. Really, up until about now, the death rate and the annual number of deaths has been falling. It's now set to increase because there are more older people coming through. And also, there was a boom in births immediately after the Second World War, which has meant that there's a bulge in the population at that time. But it won't start falling at 2040. The annual number of deaths is set to keep increasing until about 2050, possibly later. And the new projections that are brought out regularly just seem to be pushing the curve back a bit and delaying it slightly, but not stopping it. And the big difference here, if you compare 2014 to 2040, is the difference in the age distribution of deaths, particularly those over 85 years. And this means that in England and Wales, deaths and palliative care needs are going to increase. So the orange line here is all deaths in England and Wales. And I'm just going to grab some water. It's always a good idea, isn't it? it's really just a precaution, but it's a nice precaution. So if we look at this, we can project onto this the number of people who are likely to need palliative care. And even if we take the most conservative projection, it's going to increase by at least the 25%. But if we have a more realistic projection, I think, which is an increase in palliative care needs as a result of this increased multimorbidity, people living longer, etc., then we're looking at potentially a 42% increase in palliative care needs, which is a major difference. And if we look within these data, what sorts of people will we see? Well, cancer deaths are certainly going to increase. They've already increased a little bit. They're projected to increase further, as you can see here. And we've mapped onto this the estimated pain prevalence, which will increase with it. If we look at dementia, then although it increased slightly, as you can see there, in the last few years, up to 2014, the projection up to 2040 shows an increase even higher than that for cancer, with a 4-fold increase in dementia as an underlying cause of death, potentially. Now, I recognize that these are data for England and Wales, and my talk is titled UK, so I attempted to source some Scottish data, and you can see here a little bit from Scotland about saying that there are over 10,000 people in Scotland who are not getting the care that they need. I haven't been able to source projection data for Scotland. Would love to, if anyone would like to work with me on that. We have done some projection data for Ireland, led by Pauline Kane, who's been doing a PhD in our group. And here, using the Irish data, we see here an increase similar to in England and Wales of dementia, which is increasing already as the Irish population is aging more quickly than that of England and Wales. So we see increase in dementia, neurodegenerative diseases and cancer, and a particular issue of the rapidly aging Irish population there. Now, the challenge with focusing on single diseases, I believe, is that they miss a key issue about multimorbidity. Now, the prevalence of multimorbidity rises with age. This is well known. And the number of diseases and different disorders that you have start to emerge in the older age groups. So as we have an aging population, we will see more multimorbidity. But over and above that, I believe that we are also seeing a rising tide of multimorbidity at all ages. Now, this is data from Canada, but I think it's very relevant to the UK. They have data sources that we don't have to be able to analyze this. But you can see here the number of different comorbidities that people have, and you can see how they are rising at all ages in this 6-year period of their study. So you see the line here, which was the peak there in their study in 2003, and by 6 years later you can see this rising tide in multimorbidity for people of all ages. So I think we're seeing two things here. The treatments and the health benefits that people are getting are enabling them to live, but sometimes with some degree of multimorbidity, more chronic diseases, affecting children as well as adults and older people, and then the fact that we have older people in this group here with a steeper rise in multimorbidity. And multimorbidity also rises with deprivation. So this is data from Barnett again, who's published a lot in this in The Lancet, showing the difference for many diseases between the percentage of people who have other conditions, so for example, heart disease and diabetes, for people who are both affluent and deprived. And what's very interesting is that you can see that across every single condition, you see a greater prevalence of comorbidities with deprivation. So this new era of patient and family needs has major implications for the care that we provide for people while they are living and also for dying. So we see more of the oldest old, more multimorbidity. We see more fluctuant trajectories of illness. We see treatments going later into the course of illness. We see more deaths. And we should reflect that for older people, physical illness has a greater social, functional, and psychological effect. And there's more uncertainty in the trajectory of illness because of the multiple morbidities and the fact that we don't understand these diseases in the populations, and they are changing all the time with the new treatments. Now, why should we be bothered about multimorbidities? Well, it has a major effect on, for example, even the simplest of statistics of where people are cared for. It also has a major impact on safety that I showed you earlier. It's well known that people with more multimorbidity have more issues around safety. But if we look at this in a simple level, it was data that we published earlier this year, and we say, this looks good, where people die and where they're cared for with interstitial lung disease and COPD, published in BMC Medicine. And during the implementation of the end-of-life care strategy, we can see that the initial upward rise of hospital deaths is now falling and fewer people are going to hospital. But lay on top of this the different comorbidities that people have for both COPD and IPD, and suddenly we see a different picture. And suddenly we see the people with comorbidities actually are not being affected by the changes that we see for people with no or one comorbidity. And in fact, for interstitial pulmonary disease, there's no effect once you get out of no comorbidity. That's not really surprising in a way, isn't it? If you have simple interventions, targeting, trying to get people home or whatever, the clinicians on the ground are going to target the patients who they think they can do it in, and that will be the easier patient who's not complicated, who doesn't have multiple comorbidities. We see a similar pattern if we don't look at where people die, but if we look at emergency department admissions. And here the data is even more worrying, because what we see with emergency department admissions is, despite the fact that we see a fall in hospital deaths, we see a rise in A&E department attendance, even despite a fall in deaths in hospital. And we see these fluctuant trajectories across all diseases, and the old neat model of the cancer trajectory, the frailty trajectory, etc., I believe is gone. We see in all diseases much more. For example, this is data from Balsavine, who's working with our group, showing the fluctuant trajectories that you can see in cancer and COPD with little difference between them. This old idea that cancer has one trajectory and organ failure has another is probably not true. And individual patients have different individual trajectories that we need to think about and respect. And the other issue that lies within this, importantly, is the question about frailty. We see a lot of people who potentially are pre-frail or frail, and this will increase for the future populations. And it brings to us the question as to how much we should start to consider working with rehabilitation services. Many of you within your hospices have rehabilitation services, so that actually you can help people get out of the frail areas and move back into the pre-frail or not frail at all areas. Now, let's spend a little time thinking about the provision of end-of-life care services. So projecting likely place of death and place of care is more difficult than projecting the numbers of people who will die or the diseases that they will die from, or even the palliative care needs that they will have. And the reason for this is because where people are likely to be cared for and where they will die is influenced by the previous trends, but also the availability of services that we have, especially if some are limited, and the incentives that we put in place for people to use or not use different services, both at an individual patient level, how we talk about them in the press, what we do, and also how they're funded. Now, the upside of this complexity, in my view, is the opportunity, because if things are going to be influenced in this way, then doing the projections means that what we project can be changed by changes in policy, practice, communication, culture. And this is where this group and Hospice UK, I believe, have a particular opportunity and role, because improvements are possible. So I show you this data with that in mind. We did this analysis to look at and model potential future scenarios so that we can say, actually, what would be the best thing to do. So we know that this can be done because we know that already we have changed in England and Wales the trends in home death. And congratulations, everybody, because you have been part of this change, and we have seen the steady fall in home deaths, which around 2007 started to rise. And it went against the projections because we made changes. It's changed more for cancer than non-cancer, so we need to be careful about that and think about the non-cancer and the implications, but we know that by doing future projections and then doing something about it, we can make change. So let us think a little bit about where people might die in future years. So Anna Bone and myself did some work taking the future numbers of people who are going to die and simply mapping the future projections forward, assuming that average trends continue. We also did a number of other maps making assumptions. If we were to continue the current trends, what would we need to have in place in terms of services? Well, we'd need to have a massive increase in the number of community deaths. And our question is, what's the capacity for this? Particularly the care home bed capacity for this type of increase, the capacity for community support, the workforce implications for this, and the training and education. Because otherwise, if we see hospital deaths flatline, and I'd encourage you to look at the paper because I didn't want to show all the graphs, you will obviously see that if these are not able to rise in this way, then where are the people going to go? They're going to go to hospital or potentially hospice. And I have a real question about this. Why? Why is this not going to increase more? Why has it not increased? And I don't know the answer yet, and I'd like us to discuss this, because my question is that, is this not an important part of the future, given that I think it's highly unlikely that this could rise in this way in the future? And even if it did, it would require a lot of input from here. And the role of hospice, which we know is of good quality, feels to me to be really important here. Now, it might need to be different hospice. It might even need to be wards or more integration in hospitals, different models. But it feels to me concerning that if this were the trend and this happened, what would the quality of care be in this circumstance without the capacity? And how would we ensure that? So do take a look at the paper, because we did the variety of different models in the paper, and I think that's quite important. We know that the 2014 World Health Assembly said palliative care should be integrated into healthcare systems, essential healthcare service for people with chronic and life-limiting illness. But how? So that takes me to today, the budget. And I apologize for this cartoon. It's actually in today's Telegraph. So take a look at the Telegraph to look for it. I think the opportunity for us actually is to think about the transformative research that we need to do to understand how, if we go back to this, how we can change this and meet the needs of this population. So we need some new models for palliative care for this very different population to the ones that we see when palliative care was first being promoted in 1967, 68, 70s. We need to have better therapies, and we need new therapies, and we can probably also repurpose some existing medications, both pharma and non-pharma treatments, for the future. We need to be able to research during complexity, and we need to urgently respond to the growing costs that healthcare treatment and services face. Now, research has already helped us and taken us a long way, despite the fact that the proportion of research spent in, say, for example, cancer that goes on palliative and end-of-life care. Does anyone know the figure? Who would put up their hand for 1%? Who would put up their hand for less than 1%? Who would put up their hand for less than 0.5%? Who would put up their hand for 0.3%? You're right. Probably a bit less. So if we get so little support for research in palliative care, and I commend the National Institutes of Health Research and many of the charities here for the fact that they do support it, but we still get very little support from big research funders in this area. Yet, a lot has been done. A Cochrane review published this year in June shows that early palliative care is probably associated with, or is associated with, better quality of life. However you do it, quite a good effect size, actually. If one systematic review isn't enough in palliative care, you get another one in the BMJ 1 month later. And what you see here, now looking broader than cancer and across different settings, is we see also a benefit on quality of life with a slightly different mix of studies, more evidence in cancer than non-cancer, but more that the studies haven't been done. We did this study in the UK, supported by NIHR. It's lovely to see them with a stand here, randomizing patients to early palliative care, integrated with a new model with respiratory services. We found a significant benefit in the primary outcome and a survival benefit, although mainly for the non-cancer patients, with no difference in total costs to healthcare or to informal carers. And Gomez and colleagues did an earlier systematic review on home palliative care. Does it increase the chance of home death? And they found more than double the odds of home death when compared with conventional care if you have specialist palliative care. But interestingly, they also found huge variation in the care models that were available. And one of the questions is, what is the best, most cost-effective, and most patient-preferred models of care for the future for us? To help them understand that, they've recently published, just earlier this year, a really nice study looking at what patients feel are the key ingredients of home care. And this meta-ethnography found 3 core components: presence of the service, competence of the service, and that's an important thing not to forget, and a feeling of security and safety. Brings me back to my initial thought about safety, because one of the findings of a study by Leslie Henson and our group in London was that one of the main reasons why patients turn up at accident and emergency departments is they don't feel safe in the community and at home. We also know that palliative care can reduce healthcare costs, especially when it's early. This is data from the group in Ireland, led by Charles Normand with Peter May. And what they found here, this is American data, was that the earlier people were referred to a hospital-based palliative care team after admission, the more likely they were to have cost savings. So what you can see here is that if you're referred within 2 days, you have the best cost savings, whereas within 20 days, you still have a cost saving, but it's not so big. And interestingly, and hugely relevant to this question of multimorbidity, they found that the cost savings were greatest when patients had multiple morbidity. Here you see a graph of the average cost savings over time, and as I said earlier, the earlier people got palliative care, the greater the cost saving, and it fell, but you still get it later, but it's not as big. But if you have more comorbidities, you also see a much greater cost saving. Another argument potentially for early palliative care. How do we trigger this palliative care, particularly in these more complex patients that are not like the cancer patients that we saw in the past? Well, and what sort of models might we have? In September this year, Maddox, myself and colleagues wrote an article looking at the potential for providing palliative care for people with chronic obstructive pulmonary disease, and how one might trigger referrals and how one might move towards more integrated working with potential models for integrated working. For example, symptom-triggered services, perhaps with short-term integrated care or integrated respiratory services and so on. And many of you here, I know, have been working with the palliative care outcome scale in the OAK project, which is fantastic to see that palliative care services are now on the ground collecting data on outcomes to help develop their services further. I know there's a workshop on that, I think, tomorrow afternoon, so do go to that. But the other thing that we've been exploring is whether simple measures like this, particularly in their simplest format, could actually be used to identify people with problems so that you could trigger palliative care, at least an assessment, rather than relying on the clinician to have to raise the conversation with the patient. And in the long term, my wish would be that systems like that would be actually put into the hands of patients and families, or potentially volunteers, to help people have, to be empowered, to be able to decide when they want palliative care. And although people sometimes have an issue about the word palliative, I think the modern definitions of palliative care can be explained and should be explained to patients, families, and the public so that they see it as a positive. And I will share with you that after the TEML trial, which I'm sure you all know in the United States, which came out with in advanced cancer, you get better survival with early palliative care. Those results in themselves had patients ringing up the hospital saying, where can I get this palliative care because it's better than any chemotherapy agent I've heard of, which is quite true. So let us return to the budget. I believe that there is no case for not investing in specialist palliative care anymore. I believe that the evidence is there. It's cost effective, it's quality. It needs to be led by hospices, palliative care specialists, our profession. It needs to cross all settings, and I feel, but I would like more data on this, that the future is that we need greater integration with rehabilitation services. I also believe that we need investment in research. We need to find ways to deal with the populations of the future, because after all, everybody in this room is somewhere in my graph in the future deaths to 2040 and belong. And so are the policymakers. So we need to find the solutions for better care in the future and not do it by guesswork. Because guesswork in complex situations does not work. There is a very simple solution to a complex problem, and it is nearly always wrong. So let's not do the simple, obvious solution or claim that it is. And palliative care services operating on the ground and generalist services will need therapies and treatments to offer the patients of the future. And we would like to be better at controlling many of the symptoms, the psychological problems, the spiritual problems that people face for the future. And I see a role for Hospice UK in this, in being the pioneer, the leaders driving the research agenda and the innovation agenda. So, I hope that we will have some questions and discussion. I'm going to end with a few take-home thoughts to prompt those. I believe that we're facing a new era of palliative care with new landscapes, and we need to respond to the aging, multimorbidity, the fluctuating trajectories, and the increased number of people that we will be required to face. And this will require transformative models of care, palliative care that is to live well as to die well. Integration, potential short-term models of palliative care, and to achieve that we will need transformative research into the complex services, the cost-effective therapies, the models of care, and the use of some of these interesting technologies that we potentially see. For example, the use of digital technologies and the electronic record to flag patients who might benefit from palliative care, to quickly identify people who are coming in and out of hospital who might actually need a referral but have been dropped through the system. And to achieve that, I also believe that we need very good clinical academics, and we need to train a future generation of clinical academics. I want us to stay true to Cicely Saunders' model, the idea of science plus caring, the combination of body and mind that affects us all. And I'd like to just end by thanking my many colleagues, collaborators, friends in this field, and importantly, the patients and families who work with us, who inform our research at the Cicely Saunders Institute, my colleagues and different funders. Some resources on the website. Thank you for your attention.
All working. Thank you very much, Irene. Very stimulating and left us a lot to think about. Can I go back to your slide from Anna Gomez and yourself in terms of the where people die care setting and the trajectory? Is there a sense, and I will read the paper after today, but in terms of the actual trajectory, can you tell if the people who are dying at home and in the care home are actually supported by hospices, or is it completely separate from the hospice intervention?
So this is the one that you mean, yeah?
Yes.
Okay, so here Of course, they are being, or many of them are being supported, but because this is just where they die. So many of them, and this is national data. So, of course, we know that many of the people here are being supported by hospices. But we only know how many and for how long through data, for example, that the Hospice UK or other organisations are collecting, or special surveys. So it is important to reflect and hope that a lot of these people are being supported by hospice and specialist palliative care services, and we would hope for that. They will, of course, also need services to help them be at home beyond the specialist palliative care services, and there's some very interesting data emerging from a discrete choice experiment about exactly what people would like. So you could hope that this group of people will be supported by palliative care services to be at home. And as I showed you from the Cochrane review, we know that if you have a palliative care service going into people in the home, you will double the odds that they can remain at home, be cared for at home longer, and will die at home. And there's a few studies that also show that if you have a palliative care service working in care homes, people are also more likely to remain in the care home and not go to emergency departments. So we do know that that will have a benefit. My worry a little bit is, will we have these care home beds? And I'd like views on that. It's a question.
I think my final reflection is I see that as a success story, in that hospices are enabling people to not come in unless they actually have discrete needs. So to me, I read that as a good news story rather than we're not actually making reach.
Oh, I agree. And I wasn't saying that we were, because this is a good news story. The question is, how do we sustain it?
I can see we've got quite a queue at microphone 2, so please go ahead.
Fliss Murta. Thank you, Irene. That was a fantastic presentation. I'm very interested in that you touched on the idea that we can change policy, because for me that holds a lot of promise. So I wondered if you'd mind looking at that slide and telling us a little bit more about what you think happened around 2007. You know, how much was it related to the end-of-life care strategy and the subsequent changes?
This one.
Yep. And then some reflections from yourself and maybe others in the audience about what are the policy changes we really need to see now. So what might they look like? And that would be a really interesting thing to just explore a little bit more.
Yeah. Well, what changed policy? You know, I actually think that of one of the really transformative pieces of work that I am proud of having done was the earlier projections that we did, which showed that if we did nothing, which was this grey line here, things would get worse. And I would agree with the point that this is a good news story, the latest projections, because we have turned things around. That's why I showed this slide and said, well done. The challenge now is the sustaining. How did that work? Well, and what was it related to? This is all natural experiment stuff, so you can't do a kind of randomized control trial. But I do believe that the fact that we showed the projections, we showed that it was important to people, and we showed some of the ways in which you could do it in evidence base in terms of services and so on, was actually helpful and supportive for hospice and palliative care services. How would we do it in the future? I do think that things like the End of Life Coalition, which Hospice UK, Cicely Saunders International and the charities are part of, is a really important thing to speak to policymakers with one voice. And to support each other in that, there needs to be compromise in developing that kind of voice. Evidence is really important. I believe that the cost data is also really important, but I also feel that the projections is very, very important because it highlights to people the future issues. But I'd love your thoughts, because I don't quite know the answer, and if there are advocacy people in the room, please answer it as well. Oh, we have somebody who's going to tell me the answer.
Thank you, Fliss. Anita?
Yes, Anita Hayes, Hospice UK. Thank you very much, Irene, and I think absolutely fantastic presentation, so much for us to take on board. And I think in terms of thinking about the importance of projections, I suppose what I'm thinking about is to 2040, actually, what is it significantly that we do need to do differently? And also thinking in terms of the discussion about comorbidities and actually it seems to, one thing that I think I reflect a lot on is how do we have much more interface and integration with other specialist colleagues working in other areas in terms of the sort of models and ways of working that that again I think you shared some of that with us, and how might we go about doing that, but also in terms of policy how we can influence that. So I think really kind of adds on. No answers. But.
Thank you. And I think the population change, so the increase in dementia, is a decision for palliative care and hospices. To what extent do we embrace dementia, or do we decide that we don't, which is a major difference. My honest view is I don't think we cannot embrace it because, one, it's such a big issue. And so I feel that there's a moral obligation to try and respond to that. But secondly, given that people will have this mix of diseases, how can we possibly go down disease-siloed routes in palliative care? For me, it's totally against what the population needs. Please. Very good questions. Don't have any answers.
Irene, thank you very much. It's very interesting. My name's Andrew Thornton. I'm a consultant medical director at Pilgrim's Hospice in East Kent. And it's lovely to see home deaths increasing and hospital deaths going down. But my question is, how much do we think that is an indicator of a good quality death? And if it's not, what should we be doing to see that they are good quality deaths?
So there's some data that Barbara Gomez and I did looking at home care and the quality of it. And I think that you're right to raise that point. Because, and it's the same with the other graph of the future projections, and why I said when I showed the home care and the care home projections, we need to ensure that this care is of high quality. And how do we ensure that? So the study that Barbara Gomez and I did in different areas of London showed that you could have a quality home death, and home could be associated with quality, but you did need palliative care going in. Particularly in the more complex situations, you did need home GP visits to achieve it as well. And to therefore do that, I do think that it's not enough just to monitor particular trends in one indicator or not. I have some concerns, and there's a paper that we're about to publish soon about saying just meeting a preference is the quality indicator. I believe that we need quality indicators that look more clearly at symptom management, symptom problems that people have, emotional distress, communication, and so on, rather than simply meeting a preference, because a preference is also subject to the quality at which a person has received the services. So my view is that we need quite nuanced things. And there are times when it's absolutely appropriate for people to be in hospital and times when it's absolutely appropriate for people to be at home. And it's more about the transition of care from one place to another, which is also why I flagged the safety issue, because a lot of work on safety is also thinking about the transition of care from one place to another in a safe and appropriate way, so that somebody doesn't bounce back into hospital. So I agree with you, we want quality and safety, and the challenge is properly to be measuring that. But I do believe we've got tools, and we in palliative care, as people say in the Oak Project are doing, could be better at measuring these things in a routine way and then encouraging others to do it in real time, so that we can do something about it at the time, as well as retrospective surveys of how it went.
Barbara.
Barbara Gale, Chief Exec, St Nicholas Hospice Care. Thank you, Irene.
I suppose I'm concerned that this is even a bigger problem that we're talking about, because we're currently not meeting to the demand that is already there. And whilst we talk about those with specialist palliative needs, you know, I would suggest that the whole population, that all of us in this room should be planning for end of life and might have a need to use hospice advice, information and things like that. So I worry that it's an even bigger problem. And added to that, that there's less money, despite what the budget may or may not bring. So I suppose I'm concerned that we're not talking about how we're going to use the money we've got differently. I'd suggest that St Nicholas Hospice Care is trying to remodel the whole service to look at how we meet a different demand, and we're going to be talking about that on Friday. But I just think this is such an enormous problem, and I think we need some more time to talk about it and debate this.
Thank you for that comment. I agree. And my only plea would be, let's do it with evidence. Even if you can only collect evidence as you go, let's please do it with our eyes open, not just do something and assume it's the right thing to do. Because I agree with you, it's critical, and you're right. I mean, that's why I felt concerned about this. What is the bed capacity, workforce training and education when we know that services are already stretched?
We have 5 minutes left and 3 people standing up to ask questions. So
can we let them all do their questions and points?
Yeah.
And I'll try and respond.
Yeah. Max, do you want to go first?
Thanks very much, Irene. I'm Max Watson, Hospice UK and Project ECHO. I guess my question is a research one. Your data, really helpful data, shows that we really need to integrate our service with other people's service in order to have the impact that the population needs. But if we do that integration, what research methodology will we need to kind of demonstrate that palliative care is still having an impact, because we're going to be diluted? We need to dilute ourselves in order to have an impact, but once we're diluted, how will we then justify getting the money to continue doing what we're doing?
Should we take the questions and
Yeah.
I'll respond?
Thank you. It's Ruth Orton from Loros, Director of Education and Workforce. You mentioned the word transformation quite a number of times in your presentation, and I think we need to remember to transform the workforce. We need to bring them with us on this journey. And if they don't understand why we're doing these things, I think we could lose people. So we need to think about not only educating and training them, but upskilling, reskilling, thinking about the new workers that are going to be coming in, how they're going to be using that technology in a different way, and making sure that they're with us on that, and how we may adapt our approach to education and training to embrace that technology. There's some great exhibitions downstairs. But also it's about how we're going to use that. We've got young people coming in to our workforce that are tech savvy, and we need to not lose them, because they will disengage with us if we're not working with them and having those resources available to upskill and transform the workforce.
Hello, I'm Louise Jenkins. I'm a strategic liaison nurse for people with learning disabilities over in Hertfordshire County Council. Very interested in your slides, particularly around deaths in care homes, and one of my experiences is around policy change and around the need for us around continuing healthcare to actually become an enabler for people to return to care homes, not a barrier as it sometimes can be at the moment. But my question was around the national mortality review that has been happening since the 1st of April into the deaths of people with learning disabilities, and how Hospice UK and palliative care services are going to take on some of those themes that are going to come out of that are very clearly going to echo some of the reports we already know, that people with learning disabilities deaths are often poorly coordinated, lack of intervention by palliative care, and how those themes that come out are going to be embedded into future hospice and palliative care services.
I mean, thank you all for those points. So Max, on integration and what research methods, and especially if it's diluted. So I'm a big fan of the Medical Research Council framework for the development and evaluation of complex interventions. I think it's really at the core of what we should be thinking about. And here we need a theoretical model and to understand the mechanisms of action. And actually, I think we fail to do that at our peril, because if we don't understand and have an understanding of what the mechanisms of action are, we may, as we move forward with this potential dilution, actually miss a key ingredient in the process of doing something. So it's all very well to have some kind of tool for people to use, but if you don't have the right environment in terms of workforce, culture, customs for them to use that tool to work with you, you have major challenges. And it may well be then implemented, and then people blame the implementation, but actually what they did wrong was they hadn't thought enough about the correct model. So I'm a huge fan of that, and it does need good science. It's why I said, please don't just let's do it, let's learn as we do it. I think that's really key. And that will involve mixed methods. And it will involve trials, because you can do trials in this situation, but it will also involve other methods, particularly to look at nuanced outcomes, such as qualitative methods, but robustly done. I do think that routine data may also help us to understand things that have happened in real time as well. The lady from Loros, I'm terribly sorry I missed your name, but the point about transformation of the workforce, absolutely right. I couldn't be more spot on, because we need the people to do this. I could agree with you. And Louise, thank you so much for raising the issue of an important vulnerable group, which is people who have learning difficulties, and how we must make sure, as we move forward with the issues that face us, we must try and include them all as an important priority and ensure that we have good individual care. So thank you.
Well, thank you very much, everyone. That brings this morning to a close. It's now lunchtime. Please do go and visit the exhibition hall. But before all of that, can we all please say thank you once again to Irene Higginson.